Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
A mission to
Delivery of. Well, I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Sam Makhoul. He is the Medical Director of Clinical Research at CARTI. Dr. Makhoul, thanks for being here today.
Thank you for having me.
So May is Cancer Research Month. Can you start by explaining why this month is so important for raising awareness and advancing cancer care?
Cancer research is the only way that we were able to overcome cancer. If you look at mortality from cancer about 50 years ago, and between 1940 and 1950, before modern research in oncology had started, we would lose about 3 out of 4 patients. 75% of patients would die from their cancer. Fast forward now 50 years later, we are at the level of saving the lives of 80 to 85% of all cancer patients. And that is thanks to research. And research was really the only instrument, the only tool that allowed us to discover the mechanics of cancer and design treatments to overcome it.
And we've heard about a remarkable new study showing that immunotherapy alone is curing certain cancers without surgery, chemotherapy, or radiation. Can you walk us through what makes this breakthrough so significant?
Yes, that is very exciting, actually. And for a long period of time, many investigators have thought that the immune system plays an important role in fighting cancer. However, we have never been able before the year 2000 to understand how the immune system does that. And then some investigators realized that there are certain mechanisms that the cancer hijacks and it turns against the immune system to inhibit or suppress the immune system. Once we understood that mechanism, we decided that, okay, let's design something that can remove that brake on the immune system to allow that immune system to exert its own function, what it's designed for. And that was the beginning of a journey that led us to the first approval of immunotherapy. We call them immune checkpoint inhibitors. And this immunotherapy was approved in 2011 in melanoma. And we started testing it in other cancers. And we realized not all cancers respond to this type of immunotherapy. And that is the study that you're citing here that showed that, in fact, if you have a type of molecular or genetic abnormality in the cancer genome, you might become more prone to responding to this treatment. To a point, in certain cases, some patients did not need to have surgery, radiation, or chemotherapy. So this study actually was unique in that regard. Why? And we will probably answer this question as we go along. But I think it's very important to understand that at this point, immunotherapy applies to practically some subsets of all cancers, but not all subsets of any cancer. And that is really an important concept. And we'll try as we go along to explain which ones would be eligible for immunotherapy.
My next question is, how does immunotherapy work differently than traditional treatments like chemo and radiation?
Immunotherapy, actually, the one that we are using now and the one that we have cited in the beginning of our discussion works not against the cancer directly. It's not going to kill the cancer. The cancer is putting the brake. Let's say the immune system is the policeman, and the cancer has hypnotized the immune system. So what we are doing with the immunotherapy, we are removing the process that put the policeman to sleep. And then our policeman will go and kill the criminal, quote unquote, cancer cells. So the immunotherapy doesn't kill the cancer cells. It stops them from suppressing or putting the brake on the immune system. And as a result of that, with the immune system being fully awake and activated now, it can counterattack against the cancer cells.
And for cancers like rectal or gastric cancer, how big of a deal is it to potentially eliminate the need for surgery or radiation?
Based on the results that was done at Memorial Sloan Kettering, and it was presented at different cancer symposia at this point, the first 12 or 13 patients with colorectal cancer who received the immunotherapy I'm talking about were able to achieve complete response, meaning the cancer was completely wiped out and there was no cancer to remove. So what happened is that the doctors checked on those patients, could not find anything, and then they started watching them with no surgery or any additional treatments. And with long-term follow-up, usually here time is our ally in order to let us know whether we have done a good job or not. Because if the cancer was not eradicated, it will reemerge again and will start wreaking havoc and causing problems. And there was nothing. So that's where we realized, and they took biopsies and stuff like that from the area where the tumor used to be, and they couldn't find any live cancer cells. So they continued following up with those patients. And as of the publication of their report, which was, I think, in March of this year, it appears that after many months, I would say, of follow-up, none of these patients have recurred, meaning there is no evidence of cancer coming back anymore. When they enlarged the study, so that was the first cohort. The second cohort of the study, they brought all types of cancers that have mismatch repair deficiency into that study. And in that group of patients, the response was 80%. So the response in the colorectal cancer group was 100%. The response, and not meaning here 80% not requiring any additional treatment. While in the other cohort that had gastric cancer, potentially endometrial cancer, other types of cancers, and as I said earlier, we do have mismatch repair deficiency in all categories of cancers, not all of them, but the most famous ones are the GI ones. We talk about them, but there are others as well. And in those cases, the responses were close to 80%.
So this new approach could change the quality of life for patients, like both during and after treatment?
Oh, absolutely. Not having to do chemotherapy by itself is absolutely significant improvement on quality of life. But let's look at the different modalities of treatment. For example, the standard of care up until now for rectal cancer, for example, is to do, initially we do chemo, sometimes chemoradiation, and then we take the patients for surgery, we remove the rectum. Now, removing the rectum is not a life-threatening procedure, but it's life-altering procedure. You have to wear a bag. Your entire quality of life would change dramatically. While if you don't need to do, and also those who can, after radiation therapy, can keep their rectum, there are some side effects related to the radiation therapy that might be lifelong side effects. They stay with you. They don't go away. So being able to spare the patients from the side effects of chemotherapy during the chemotherapy, mostly some of these side effects also of chemo can be delayed and happen for a long period of time, like neuropathy, for example. Not having to lose your rectum is a great plus for the patients, and the long-lasting side effects from radiation therapy, all those are not there, right? We spared the patients from going through that. Now, granted, immunotherapy, which is now really, relatively speaking, safe for the majority of the patients, unfortunately, there are a few patients who are going to have major side effects, and some of these side effects can be fatal as well. And I would talk about that later if you want, but I'm talking here the overwhelming majority of the patients in my hands and in many other physicians' hands, they don't get any of the side effects we talked about earlier.
So this seems like a part of a larger trend towards more personalized cancer treatments. How is cancer care shifting from a more is better mentality to a more targeted, less aggressive therapies?
That is really a very important question. We have entered into the personalized treatment era. At this point, it's really not one size fits all at all. And in the old days, for example, we started initially with surgery. We discovered that chemotherapy can add benefit. Everybody would get surgery and chemotherapy, and then radiation therapy and target therapy, and so on. Over time, we realized adding more is not adding benefit to everybody. And we realized that now, thanks to the genomic analysis of the types of cancers that we are treating, we realize that not all subtypes of any type of cancer, let's say breast cancer, colorectal cancer, gastric, name it, not all types are going to respond to the same type of treatment. Not only this, we discovered that not all cancers are as lethal as we initially thought. Some of them can be treated with simple surgery. We have the example now of breast cancer. There are varieties of ductal carcinoma in situ, meaning the cancer that has started in the milk ducts but has not invaded into the fat surrounding the milk ducts. There are certain varieties that we call them very low grade, small size. You can watch them and without doing anything, provided that you have the team that knows when to intervene if there is a need for that.
And Carti is known for offering leading edge cancer care. How are you incorporating immunotherapy into your approach here?
Yes, and that's really a very interesting question. Different systems adopt different ways of determining what to give to patients. We have aligned our organization on the NCCN guidelines, and we consider the NCCN guidelines as our guiding principles. And I don't know if you know what the NCCN guidelines are, probably the National Comprehensive Cancer Network. These are the most prestigious cancer institutes in the nation that started 30 years ago, trying to see if there are any guidelines for what is the best treatment for this or that cancer today. And these guidelines are online. They're free. You can access them anytime you want. And also they tell you they are updated practically 2 or 3 times a year for every single cancer. And so there is a huge army that is now of experts that work on that. And all this is supported by public grants for research to help maintain all these data. So you can trust that the information that is presented in these guidelines is free of bias and other financial incentives for financial gain. Our organization uses these guidelines as our foundational pathways to decide about which cancers can benefit and need immunotherapy and which cancers don't. And our compliance actually with these guidelines is close to somewhere between 90 to 100%. And I want to say here that complying with these guidelines to this degree, that tells you the level of discipline, how an organization sticks to the evidence in order to present their patients and provide their patients with the appropriate treatment. So our compliance with the guidelines recommendations is phenomenal. Now you might tell me why it's not 100%, because there are cases that don't fit, and we need to use our research and the art of medicine, I would say, to answer the questions.
And finally, during Cancer Research Month, what can people do to support continued innovation in cancer care, whether it's through advocacy, donations, or simply staying informed?
I think all of the above. You have, I think, summarized it in one single statement very nicely. Certainly, we have funds here for research at Carti, the Carti Foundation, that accepts donations for research. And some of our research projects are indeed funded by the foundation. And that is extremely helpful because sometimes you have a very good idea, but the funding mechanisms can be a little bit difficult to get. And so the foundation will provide us with that support. On the other hand, advocacy is so important, especially today. And because this is the research month, in my opinion, everybody should speak loudly, I would say, in support of research. Every dollar that is invested in research, it generates about 2.4 or $2.5 of economic activity in the community. So it's not only that we are not discovering the new drug, but we are putting many people out of business, basically, as a result of drying out this research funding. So supporting research is truly, in my opinion, the obligation of every single citizen. This is the $1 that you can pay in research that can generate $2.5, but also discover the drug that would save your mom and your daughter and your father. This is the way I look at it, and this is what we need to do. In addition to be curious, there is always, research is not an afterthought. Every time everybody comes to us with cancer diagnosis, whether it's early stage or slightly advanced or more advanced, we consider having a research option for those folks is an obligation from our end. It's not a second, or afterthought. It's not something that you would do after you have kind of failed to find anything. There is always room to improve. Until we get that 100% cure rate, there is always room to improve, and research is the way. Ask your doctor, is there a research option for me?
Dr. Makhoul, thank you so much for not only talking about a very complicated procedure therapy in a way that I understand, I know our audience will understand, but also thank you for sharing your work that you're doing, the important work that you're doing at Carti. Thank you so much.
Thank you. Thank you for having me.
And that's it for this episode of AFMC TV. Have a great day, and thanks for watching.